Thank you all for being here. And I think for time, we'll go ahead and get started. So thank you all for being here and attending our panel discussion. Our hope in exploring the dynamics of suicidality in pregnant and postpartum individuals by sharing both the perspectives of those who've experienced suicidality personally, as well as those in helper roles, is to increase awareness and to reduce stigma of those seeking support, and also for the helpers looking to provide responsive care. My name is Daniela. I want to acknowledge our our soon-to-be six, one is running late, amazing panelists that are joining me today: Elise, Brittany, Dr. Neha, Jessica Walker, Jessica Ruiz, and Emily. We're going to begin with a brief presentation to introduce you to what perinatal mental health is and suicide. And following this, we'll have the panelists introduce themselves to lead into the discussion. So to begin, oh, Nargis, are you controlling this? Sorry. 1 second. I'm so sorry for some technical difficulties on my end.
Can't you not see my screen? I am controlling it.
Oh, thank you. Great.
Yeah.
Myself, Lise, and Brittany are here from Postpartum Support International's California chapter. We're on the board of directors. And I just wanted to share what our vision and mission is, especially around creating inclusion and awareness in the prevention and treatment of mental health issues related to pregnancy. So I hope that this presentation will be informative, and so you can carry this information into your communities. If you can go to the next slide, please, Nargis. So we're going to talk a little bit about first what is perinatal mental health, or we're talking about perinatal mood and anxiety disorders, which we'll shorten as PMADS. So in this presentation, that's going to be super brief, we can't possibly cover everything. So we're just going to highlight some things that are important so that you're aware of some concepts before we get into our panel discussions. But the perinatal period includes prenatal and the postpartum time, and PMADS can happen anytime during this period. Oftentimes we think of postpartum depression, that's what we hear. And this is a really big umbrella term that people use that somehow captures everything, but there are specific perinatal mood and anxiety disorders that are important to distinguish. It can often be a misnomer too, because people say postpartum depression, and the idea is that this is something that only happens in the postpartum period, where we know this can happen from point of conception and anywhere after, but also folks that are trying to conceive. So when we think of PMADS, we're thinking of anything that's affecting the mood, anything that's affecting anxiety and other disorders. Sometimes we're forgetting to include substance use or even eating disorders or ADD, ADHD, and so much more. So anything that can impact anyone's functioning, or what we call live, laugh, love, those are the things that we want to be aware of. And also that this can impact anyone. Next slide, please. Folks that are touched by perinatal mental health or PMADS are all birthing people, but also anyone that's a caregiver who takes responsibility of raising a child, but who might not identify as parents. And so this includes a really broad range of people. And so we want to be really mindful to be inclusive of all the different people that are included of this. Sometimes very binarily, we might think of new moms, but really this could be dads, partners, or anybody that's really involved in this process of supporting folks becoming parents or parents themselves or caregivers. Next slide, please. So oftentimes this concept of what baby blues is confused with what postpartum depression is, and it's often hard for people to differentiate between the two. Baby blues is something that a lot of people might typically experience, but it's not something we consider a perinatal mental health disorder. It can last up to 2 weeks, and it can sometimes resolve by itself. Oftentimes, a lot of the symptoms may resemble something like postpartum depression or something else, but the main features are that you can still feel like yourself, have moments of happiness, and it's not persistent or pervasive. Next slide, please. Whereas postpartum depression, since it's something that's most often talked about and most often screened for and researched, is a clinical diagnosis. And the onset can happen anytime from pregnancy through the first year of after childbirth or beyond. And you can see the list of symptoms here that it includes. And also what differentiates this is, like I was saying, that these are going to be more pervasive, more persistent, and can be really difficult to get support without other interventions or support networks. Next slide, please. Some thoughts of folks that are experiencing postpartum depression or other PMADs might look like this. That folks are feeling like they're constantly worried, they're numb, they're feeling like they're in a fog, want to run away, or having really scary thoughts. And most common also is that no one understands. So there's a lot of isolation that could come from postpartum depression. And even though these are thoughts that are we're highlighting in terms of this PMAD, these thoughts can show up in other types of perinatal mental health disorders. And there's also other thoughts that aren't on here. But it can be really an isolating experience. And sometimes people aren't aware they might be having these thoughts. Next slide. There's a lot of assumptions and myths that can also contribute to this. And this is either ideas, phrases, or concepts that are put out there by friends, family, society, things we might not be aware of, that we want to be mindful of when we're saying these things or checking our own assumptions and beliefs, such as all pregnancies are planned. We know that actually about 50% of pregnancies are unplanned, or that breastfeeding is natural and it's so easy. When we hear the phrase so often, breast is best, breast is best. And sometimes people can have a lot of stress that comes from breastfeeding or a lot of challenges. And so people can start to feel like they're a bad parent, or why is this so difficult for me, or I'm having trouble. And really when we say fed is best, or I will instantly bond with my baby, this idea that as soon as you find out you're pregnant, or as soon as baby arrives, things are going to feel very different. And then if you don't feel that bond, people can start to worry, well, is something wrong with me? And because of the isolation and shame that comes with having some of the thoughts that we talked about in the last slide, people may not want to share that they're having these thoughts that come if they're not experiencing some of the things on this list. Next slide, please. There are also some assumptions and myths about parenthood. What does it mean to be a good parent versus a bad parent? So good parents don't get depressed or anxious or traumatized, or hearing you're having a baby, you can't be depressed, but the baby is healthy. Focus on that, with this idea that as long as the baby is okay, the birthing person, it might not matter what happened, right? You should just be grateful. You should just be happy. And that can start to minimize or invalidate people's experiences. There's also provider bias that, towards cisgender heterosexual moms and babies. And so the way that folks are interacting with providers may have like a binary idea or assumption of what parenting might look like, or what the family system looks like. So if someone they think is mom shows up, they might ask, is dad babysitting today? Or otherwise, like, where's dad? Where's mom? Or having trouble differentiating, oh, there has to be this one specific parent. Are you mom or dad? So also the way people are experiencing different providers and healthcare systems can also impact how people are feeling. Next slide, please. All right. And so perinatal mental health in the US, it is perinatal mental health disorders are the #1 obstetric health condition and complication. In 2022, the CDC reported that mental health conditions make up 23% of pregnancy-related deaths. And these were made up of suicide or accidental overdose or poisonings. Next slide. And then also, we know that with perinatal mental health disorders, there's a huge disparity. We see higher rates in families of color. We also can't forget about non-gestational or non-birthing parents. 10% of fathers or partners end up experiencing this. We know that there's an underdiagnosis and under treatment. And then also, even though we know that these are common and treatable, 75% of people with perinatal mental health disorders don't receive treatment. And if we had like 3 hours to talk about this, I'd ask, why do you think that is? We're going to talk about that right now. Next slide, please. And so some factors that contribute to this is too little screening. Even though there are some laws and mandates that say that screening should be done, it's still not being done regularly or as often enough or with enough oversight. Maternity care deserts exist, so there's little places for people to get care. And we also know that there more places that are shutting down prenatal care. I think just recently in this past month, somewhere in Southern California, Hemet shut down like their labor and delivery hospital. So we're seeing more and more of this. And then a lot of shame. Shame can deter people from seeking help. And then there's also a lack of outreach. If folks are having trouble themselves, so it might be mistrust of providers, fear of what if I say something is happening, or exacerbation of their own mood or anxiety symptomology. So maybe they're going through such a period of unwellness, it's hard to reach out. Next slide. And then you have to click one more time. Thank you, Narcis. So in California specifically, we make up 1/8 of all US births. So we're ranked actually #1 in births in the country. And also, typically when we think of PMADs, we say about 1 in 5 people experience this, but in California, it's actually 1 in 3. So the rates are much higher, and then about 5 to 14% have suicidal thoughts and ideation. Next slide. And then the impact of untreated mental health disorders is preventable maternal deaths, preventable conditions. We also know that it causes other like family dysfunction, difficulty between relationships, parent-child dyads. There's financial problems. And if we also think about the cost that shows up in healthcare systems in 2017, so I imagine this is much higher now, the estimated cost across the country was $14 billion for untreated PMADs, which came down to about $31,800 per mother-child dyad. Next slide. But the DSM, which is the Diagnostic Statistic Manual that a lot of clinicians use in settings to diagnose some of their clients, they don't have a distinction of perinatal mental health disorders or mood and anxiety disorders. And that's really important because if there's not a distinction, we are having trouble, and we meaning there are a lot of people that are interacting with folks that fall under the category of who's touched by perinatal mental health disorders. They're not having extra training or education or awareness of how to do differential diagnosis, or what's the difference between postpartum depression, postpartum OCD, postpartum anxiety, postpartum psychosis, which the difference between that can inform treatment and also inform outcomes. And that's directly also related to things that could be preventable deaths. Next slide. And so a little bit about maternal mortality and suicide rates. So like I said, mental health conditions account for nearly 23%. And 20% of maternal deaths are due to suicide. This is actually much more common than deaths by hemorrhage or hypertensive disorders, which is really shocking. And then even though we know suicide can happen anytime throughout the perinatal period, there's a breakdown here of what studies have shown when attempts occur. So 62% of pregnancy-related suicides occur between 43 days to a year after postpartum. And so it is helpful to know like when we are seeing the majority of these attempts take place. Next slide. Also, when we're considering like reporting suicidal ideation, and we know there's so many reasons why people may not report or self-report, but from the information we have for people that have reported, depression has been linked to, like, increase of a depression has been linked to folks that experience suicidal ideation. And then we can see here that there's certain groups of folks or certain communities that are more likely to report suicidal ideation than some other folks in their communities. So with Hispanic and Black women are 2 times more likely to report suicidal ideation, as well as Indian, Indigenous, Native American, Indigenous, and Alaska Native maternal deaths, or the mental health conditions, are the top underlying cause. Next slide, please. And then data from the 36 Maternal Mortality Review Committees, the CDC determined that pregnancy-related deaths from suicide are 80% preventable. So if we think about this, knowing how to support people, how to do screening, how to recognize signs or symptoms, how to provide supportive, non-judgmental, culturally responsive care is really important into improving outcomes and reducing the maternal mortality rate. Next slide, please. All right. And so there's a number of contributing factors you can review here that could be used to identify risk for PMADs. These are things you might see as risk factors for any other mental health condition, but what's important is the specificity that some of these things are related to the perinatal period. And so thinking about if you are working with a client, a patient, or someone that's a loved one, being aware of any of these things are happening and how to provide support around this time. Next slide, please. So all of these conditions are treatable. There's different types of forms of interventions, whether it's psychopharmacological, counseling, behavioral, short-term, long-term, anything like that. But the most important message that we want to send people is that you're not alone and you're not to blame, and with help you can heal. So I'm going to stop the presentation there, and we can talk about at the end of our time together, some resources that people can know about or access in order to help support themselves as helpers, or help support themselves or someone that they know that might be experiencing PMADs. And so we'll provide you all of those links in a little bit. So thank you all for that super, super fast 101 on perinatal mental health. If you're interested in learning more, you'll find out how at the end. But now I want to take time to introduce our amazing panelists. So all panelists, it's such a privilege and a wonderful honor to have you here. And so I'm going to start the discussion by having the panelists introduce themselves. So if you can share your name and maybe, a story of what led you here and what connects you to this work.
I can start. Okay. Hello, everyone. Thank you, Daniela, for this wonderful presentation. My name is Dr. Neha Kinsara. I am a certified perinatal psychiatrist. I am a double-boarded child, adolescent, and adult psychiatrist as well. I've been practicing with the Amen clinics for the last 8 years, and I've been in their Dallas location for the last 3 years. My main focus is on building research through SPECT scans of postpartum women. We do SPECT scanning at Amen Clinics, which is a very next-gen cutting-edge psychiatry practice. And that I am collecting data on postpartum period between birth and even 2 years. I know the definition says 1 year, but I have suffered with postpartum depression myself for approximately close to 18, 20 months. And so I love doing what I'm doing. I do treatment management, medication management, therapy, holistic treatment for postpartum women, preconception counseling, a lot of different things in that area. So a couple of things that got me close to doing this was PSI. I discovered PSI through a private practice in New Orleans when I was not even pregnant at the time. And I got close to the women empowerment area. And I thought there's very little data on the maternal side for, I mean, as when we link it to postpartum, there's barely anybody out there who you know give out any sort of help or be available. So and I was practicing in New Orleans where we had Katrina, so I'd seen people with postpartum PTSD, and then they had childbirth that caused some of the symptoms of PTSD or chronic PTSD when they delivered kids during Katrina kind of come back. So that kind of led me to it. And when I saw really hard cases of why are people not coming forward, I saw all kinds of people, races, different ethnicities. And I'm like, I think I need to be an advocate for this population. That's where my journey started in 2015. And then I got pregnant in 2019 out of the blues. And we were not expecting to get pregnant. And when, as Danielle suggested, most of the pregnancies are, yay, surprise. So the surprise was very pleasant, but I would say that even though I have been an advocate for maternal mental health for so long, I thought it came with a manual and I knew it all. But when it hit me hard, I'm like, oh my God. And it was the worst time because my baby was born during COVID, almost like he was born in February, March, COVID hit in 2020, and then the world shut down. I didn't have resources myself. I mean, I reached out to PSI, I did some therapy, and I got myself on some natural supplements. I was very close to going ahead and getting myself on medications, but supplements and natural ways of dealing with postpartum depression and anxiety made things better. I am very, very close to this group of women, and I advocate, and I'm pretty much going to be on their board of directors for PSI in Texas. So that's kind of me in a nutshell. And I have my Instagram, which is all supportive of postpartum, preconception, women's health, and it's at Dr. Neha Kinsara, which is in the chat. Yeah.
Thank you. Who would like
Thank
to
you.
go next?
I can go next. My name is Emily Sims. I am a mother of three, first of all, personally, but then I am also a certified nurse midwife now. My daughter is now 11. My boys are 7 and 2. I graduated nursing school when I was very, very pregnant with my daughter, and then started a new career in labor and delivery. So that was a very stressful time. And looking back, I think I had a little bit more postpartum depression and anxiety than I realized. I just didn't see it in myself. I got pregnant again when my daughter was 3.5. And that's when things really kind of hit hard. I was working full-time as a labor nurse and doing my doctoral program in nursing. And I also had hyperemesis gravidarum. So I was very, very sick. I had a lot of risk factors for PMATs. And about halfway through my pregnancy, I started having thoughts about killing myself. I truly, in the deepest part of my heart, believed that my children would be better off without me because they deserved better than me. I knew that my daughter would remember me and be sad for a period, but I believed very sincerely that my husband would find some other woman who would be a better mother to my children than I could be. I was convinced that I was worthless, and I just loved them so much that I wanted to be selfless and remove myself from their lives. I started having intrusive thoughts about driving my car off of a bridge so that my unborn son and my daughter and I would all die together. And that scared me a lot. And I knew I absolutely would not ever do it because that would be a very scary thing for my daughter. It wasn't because I didn't want, to do that. It was because I knew it would scare my 3.5-year-old. So with all of these things happening, I finally found the courage after weeks and weeks of just sheer agony to talk to my CNM at my next prenatal visit. And that was one of the hardest conversations I've ever had. It took a lot of courage just to bring that up. We talked about the risk of medication during pregnancy versus the risk of untreated depression during pregnancy, and kind of where I was mentally. I didn't need to be hospitalized at that point because I didn't have a solid plan. I didn't really want to die. I just thought that that was going to be best for my kids. So we started some medication, and the feeling of relief, I just remember driving away from that appointment thinking, maybe there's hope. Maybe it's not the end of the world right now. The medication did start helping after a few weeks, and I could finally see that my brain was lying to me, and that I was a good mother and that my kids needed me, not somebody else. I graduated with my doctorate and started my new career as a certified nurse midwife, and I got pregnant with my third baby in 2021. We had moved, and I called my new doctor and said, listen, this is my history. I know I haven't made a prenatal appointment yet, but I need a referral for therapy. I need antidepressants. I need anti-nausea meds just to have on hand. And that really helped me get through that next pregnancy. I am now over 2 years postpartum. I'm doing very well. Moved again. I'm now in the Houston area. I am a certified nurse midwife, and I try to be a lifeline to my patients like my midwife was to me, because she was absolutely vital in saving my life during that second pregnancy. And I hope to be that for other people now.
Thank you for sharing your powerful story and lived experience. And I'm so glad you're here with us today, sharing this from the perspective of being healed and helping others heal.
Thank you.
I can go ahead and go. My name is Brittany. Excuse me, sorry. My story actually started when I was teaching, and I was a special education teacher and got pregnant in 2018. Can't even remember dates anymore. And we had a scare very early on in the pregnancy where we thought we lost the baby. and went to Disneyland thinking that we had lost the baby, and we had not. So through that time, I developed depression because I was convinced that I could not carry a baby and that my body had already failed. It was very, very traumatic moment for me. When we got to 6 months pregnant, I was struggling at my job with student behaviors and such, and it was definitely very overwhelming. And at that time, I got taken out of work on antidepressants for the first time. It felt very shameful for me. Made it through a few more months, and I ended up having my first son in an emergency type situation due to preeclampsia, with a very traumatic birth story. I did put a couple podcasts I've been on in the chat, so if you want more of that story, it's there. But because of that story, I developed postpartum PTSD, which I kind of white knuckled through for a couple years. For 2.5 years, I white knuckled through it and thought I was, I'm fine, I'm fine. But I was having blackouts and nightmares and a lot of current panic attacks regarding the hospital. And it was quite stressful. But when I got pregnant with my second son, we were very excited and I thought everything was going to go fine. Days after we found out we were pregnant, before we had told any of our family, my husband cut his thumb off at work, which sent me straight into a downward spiral because it was also first day it was 2021. It was the first day that the hospitals were closed again because of a COVID spike. So I wasn't able to stand. It sent me straight into a PTSD downward spiral. Excuse me. For the next month and a half, I have zero memory because I did not sleep and I did not eat. And one thing I do remember is similar to how what Emily said, having this idea that I'm not a good mom. It's not even for me to be here. Kids would be so much better without me. And I attempted to drive into traffic in front of the local hospital, actually. And a few days later, I ended up with a new psychiatrist and shared with her everything that I was feeling. And she told me there wasn't anything she could do for me because I was already on the highest dose of my medication. So I ended up doing my research and driving the 2.5 hours to El Camino Hospital in Mountain View, which is one of only 3 inpatient perinatal centers in the United States. And put myself into the hospital. So because I was so terrified of my plan and my attempts. And I spent a week hospitalized and then spent 10 weeks in their mom's maternal outreach something services, receiving social support and peer support and medication support. My second son born via C-section, which I requested, elected to do to avoid the trauma of my first birth because I did end up with preeclampsia again. And it was so much smoother and so much happier. And within a few months, I got involved with PSI and the climb, and the rest is history. I now work for PSI. I'm on the board for PSI California, and I volunteer on top of it all. My whole life is PSI. But through this process, I've also been able to understand that I'm somewhere on the neurodivergent scale, that I'm pursuing diagnosis now to better understand why she and why much discomfort around pregnancy. And so now I'm able to understand and look back a little bit more of understanding that there were more things at play on top of the trauma and everything else. So now here I am as an advocate.
Thank you, Brittany. And I just want to share that I was talking with Brittany when we tabled like a mental health matters day in Sacramento, and we were talking about stories, and Brittany shared her story. And I was like, why are we not talking about this? Why are people not sharing their stories about their experience with suicidality? So this is probably happening because of the conversation we had. So thank you so much, Brittany.
Hi, everyone. I'm Elise Springer. First of all, thank you, everyone on the panel here, for sharing your stories. You know, I feel a little ancient on this panel because my kiddo is now almost 15. And to put it in context, there was no Instagram or iPhone when I had my baby. And I was a licensed therapist already when I had my first. And I was in therapy myself, went to my gyne at about 4 weeks and said, I'm crying every day. And is that normal? And the response was, that's just new motherhood. And I went to my therapist and I said, I'm crying every day. And they probably said something about, you know, my psychoanalytic history. So, you know, this is sort of the old days before screening was mandated and before there was very much online. I literally thought to myself after I went to a training on on PTSD, I was like, is there PTSD after birth? I have no, I think that's probably a thing, right? And I had to look up in all the journal articles and bring it to my own therapist and say, hey, this is a thing. And, you know, ironically, I'd even worked on a suicide hotline for many years at the beginning part of my career. So again, I wasn't working in perinatal because it wasn't particularly a field at the time. One of the things that I would say about my story that's so common is that many of us who work in the perinatal field do have our own personal experiences, right? We all have our moments of finding our way here because there isn't very much training both for ourselves and for clinicians. And I'm now, you know, as I mentioned, a licensed therapist. I've been working in perinatal for quite a long time with like a variety of different organizations. I am aware of our time, so I'm going to pause it there. I'll put a couple of other things in our chat just so we can get to further discussion. But I just also want to thank very much everyone for sharing their personal stories because that is how we destigmatize perinatal mental health. So thank you.
Hi, everyone. Good morning, good afternoon. My name is Jessica Ruiz. An OB once described me as a boring pregnant patient, and I assumed labor and delivery would be the same. However, in April of 2023, I experienced a post-delivery hemorrhage, and I woke up in the ICU to learn that I was in cardiac arrest for 4 minutes. A team of 40 worked on me, and a total hysterectomy was conducted. I was evaluated by a psychologist, psychiatrist, cognitive therapist, and the diagnosis, at least for insurance purposes, is adjustment disorder mixed with anxiety and depressed mood. This was also accompanied with thoughts of hopelessness, a lot of shame, and intrusive thinking. I needed a lot of help when I got out of the hospital, and I would think sometimes maybe it would be easier on everyone if I just went away. But I also thought, well, they can't have my daughter. She'll have to come with me. And I was so embarrassed to think that. And I thought if I shared this or admitted this to anyone, what if they take her away and I actually need her? So through my trauma and grief, I now volunteer as a peer group facilitator with a pregnancy infant loss support center, which is located in Calgary, Canada. And my mission is to spread awareness of birth trauma. I've never even heard of that. All the classes that I took, I've never even heard of a birth trauma. And also the psychological challenges that follow. I'm a huge advocate for that. And the potential emotional growth around grief and loss.
Thank you so much for sharing, Jessica, and sharing your story and all of you. Like as Elise said so eloquently, I can't put in my own words. And yes, this discussion is so important because you are reaching not just everyone that's at this panel, that's at this talk today, but whoever's going to see this recording, and then hopefully so on and so forth. So your stories and how you are still here today and the work you're doing is very inspiring. So thank you. This is for Elise, Emily, and Dr. Neha. In your profession, practice, or personal experience, what are some barriers you have observed or experienced that prevent pregnant or postpartum individuals from seeking mental health, seeking help for their mental health issues during this perinatal period?
Well, sorry, I'll jump in real quick here. Just in terms of like picking up on all the stories that we're hearing, right? There's some common themes, which is lack of awareness. And I think, you know, lack of awareness and education. And then I think also stigma, right? I mean, again, that's a huge piece of it, which is a barrier to seeking help is just this sense of this isn't something that is a mental health concern, right? Separate from who I am as an individual, there is something wrong with me. And when we see such profound constructs of what new parenthood is supposed to be in the media, in our community, and the lack of discussion of honesty, I think that a fundamental piece is like, I don't know what is wrong with me, but I know that there is something wrong with me. I must be wrong. And that kind of real profound piece is so tricky and a real barrier. Then, when people do have the capacity or the awareness or the knowledge to reach out for help, a lot of times they're met with really broken systems in Brittany's case, or they're met with lack of education in Jessica's case, right? And I think in my case too, I think a lot of times it's that combination of lack of structural support and then also lack of provider knowledge combined with stigma.
Yeah, I completely resonate with Elise completely. I think the number one cause is stigma. And the presentation that I hear all the time is maybe after 6 months or a year when things are getting to settle, they finally come see me for medication management, and the depression has been worse. And I asked them why they didn't show up earlier, and they were like, "Well, the usual response I get is, isn't this normal? We thought this was normal." So they don't know how to distinguish the normal from the not normal, because I'm not going to call it abnormal. And feelings of just being down or tired with a lack of sleep can cause mood issues, according to them, was normal. But when they went back to work after their maternity leave, and then when they figured out they were not able to function, they had depression or anxiety, this constant dread about the child or themselves, their attention deficit. They asked for some help, but the family members picked it out and they said, something's wrong with you. And they themselves did not have that insight to understand that something was wrong with them because they thought it was a fine, it was a part of this whole process. The other thing that I usually come across is they don't have support. How many people in this country actually have support after childbirth? I was lucky to just have my mom here. They had shut down all the borders post COVID, so nobody could go in and out of the country in general, like anywhere in the world. My mom literally just arrived 15 days earlier and she got stuck here, which was a blessing in disguise, but I had the worst postpartum. I mean, I did not want to mention as being the first speaker here opening up, but I did drive myself to a point where I was sitting at a lake thinking I would be better off dead if I just drove in, and my mom's there, my husband's there, they're taking care of my kid. The only thought that prevented me was, what if my child actually wants to see me once before I leave? And that got me back. So it's really sad how a lack of support system, the stigma, the very thought that, hey, I'm gonna go see a doctor and they're gonna get me on medications. That's not the end of the world. We could just do therapy, we could do something holistic. But yeah, these are certain barriers. And again, cultural beliefs and ethnicities. I mean, I'm of South Asian background, and the where I grew up back home in India or South Asian countries, you don't seek mental health. Your people around you either stigmatize you if you do that, or your symptoms are either blown out of proportion, or you are targeted for being called that something's wrong with you, because everybody in this country just kind of deals with their own thing on their own. You're not supposed to have these symptoms. You're just supposed to be happy because you just gave birth to a child, but nobody realizes how much shift in hormones or the amount of efforts are put into this. So there's a lot of cultural, ethnic stigma, lack of support, breastfeeding, a lot of different barriers to presenting in the first 3 months, which is so crucial.
I completely agree. That's exactly what I was going to say as well, is the stigma and the shame surrounding it, because you're pregnant. What do you mean you're depressed? You're supposed to be joyful that you're pregnant. And I was so happy to have my son coming, but I also felt like the problem was me. It was not with him. I was thrilled for him. It was me. There was something wrong with me. And it was really hard because I was supposed to be this strong woman. I was supposed to be a caregiver for others. And now I am not well. And it was really hard to go in and admit that I was not in a place where I could pull myself out of this funk. Like, it was so far beyond any kind of, I don't know, non-pharmacologic at that point. I was very, very unwell, but it was hard to admit that. And then I think the other thing that I hear a lot is that prenatal visits, you go in, you have your blood pressure taken, they listen to the baby, they say, "Are you good?" And then you leave. It's
Exactly.
a 5-minute visit.
Yeah.
You don't, it's not a space where you can have a long, drawn out, very emotional conversation.
Yeah, honestly, I wish they had screens for depression, the Edinburgh, that's used so commonly postpartum, to be used while you're pregnant, even pre-conception, even if you're ready for this kind of stuff.
I
Yes,
would like to do it at least once every trimester.
absolutely.
And,
So
and
that,
it is different in different states. Sorry, go ahead, Elise.
yeah, no, I was just going to say, I mean, that's the ACOG recommendation, right? So
Mhm.
the ACOG recommendation is screening once per trimester, but it's really hard to enforce. And if you're following along in the chat, I talk a little bit about this. In California, we have a bill called AB 1936, which does attempt to like really increase screening. However, it's only once during pregnancy, once postpartum within the first 6 weeks, and then up to the provider's discretion subsequent to that. So it doesn't have quite the teeth that we need it to, but it, you know, again, some of the other prior bills just said, hey, if you are a labor and delivery unit, you have to have training in perinatal mental health. And then you also do need to screen, but there's been very little clear consequences if that does not happen. So we should all be following the ACOG guidelines, Emily, absolutely, once every trimester, because the biggest predictor for depression in the postpartum period is going to be in preconception and perinatal and during pregnancy.
Thank you so much for pointing that out, Elise. And I think this ties in perfectly to the next question for Brittany, Jessica, and Emily. So reflecting back on your personal experiences, what do you wish providers or helpers knew or did differently? Or conversely, was there anything that was particularly helpful that you want other people to know, whether they're providers or people that are going to be helping?
I think it was really helpful for me to hear that there are other people, that I was not the only one who was depressed while I was pregnant and having these horrific, scary thoughts, and that there are, of course, risks to medication, but there are also risks to untreated depression and anxiety and mood disorders that will also affect both you and your baby. And then just the reassurance that it wasn't my fault, you know, that it wasn't something that was wrong with me as a character flaw, that this was something that is going on in my brain. And the reframing of it as, we're not using medication as a crutch to make you artificially happy. There's something going on physiologically in your brain. And if you were having vision problems, we would give you glasses for that. Well, you're having this chemical thing, so we're going to give you medication to help with that. So kind of reframing it as, you're not weak, there's nothing wrong with you. This is just something to help you function the way that you should.
I kind of have a story to share that I think reflects what I think would be, that would help with things being done differently. For myself, again, similar to Emily, that feeling the suicidality during pregnancy, and feeling the depression and anxiety during pregnancy. My OB referred me to, at the time, what was thought to be the only trained psychiatric nurse RN in our area. RN, NP, just kidding, nurse practitioner, who was qualified to treat postpartum patients. And I was referred to her when I was 6 months pregnant. And I wasn't able to see her until I was 3 months postpartum because of the backup in getting in with her. I saw her for a few years. And when a few months before my second pregnancy, she retired, and she told me, and I told her, I'm planning on getting pregnant again. What do I need to tell my next psychiatrist? And she said, well, when you get pregnant, you should be fine. And you might even be able to come off your meds, because pregnancy typically helps depression and anxiety, which we call BS on that. In my lived experience, that's complete BS. And I've already shared that story. But just a month ago, actually, I took my son to he receives intensive psychiatric treatment for his own disability. And while we were there, that nurse practitioner, when she retired, began volunteering at the intensive services unit and ran into her. She's not his doctor, but we ran into her, and she remembered me and asked how things were going. And I told her my story, and she said, "Oh, I didn't know that people could be depressed during pregnancy. I didn't know that was a thing." And my mind was blown that someone who had been a nurse practitioner working with postpartum patients for so many years had no idea that there was such a large population struggling with depression during pregnancy and struggling with suicidality during pregnancy, and that she had no idea about that. She also did not catch my PTSD. She just thought it was major depressive disorder, and anxiety, which is actually not what I have. I have PTSD now based on the correct diagnosis. And so it's that education, that continuing education, even for the older psychiatrists and older doctors and older psychologists, older everyone who have been in the system for many years, and giving them that education and understanding that we exist and we're not alone. Again, I also thought I was this abnormality, and I also fell into that train of thought beforehand that all of these women who would, trying to think of the word, all the women who ended their lives postpartum or during pregnancy, all the women who ended their children's lives postpartum or during pregnancy, I fell into that category of thinking that they were this outlier, when in reality I also fell into that category of experiencing those feelings and could have done that myself. So there's also the shame and stigma there that I've had to let go of.
Daniela, do we have time for one more?
Please, you can go ahead, and I would love to hear your stuff.
Yeah, I would say for providers, destigmatize suicide ideation. I've come to learn that there's a range or a scale. Everyone thinks about their death at some point, but that doesn't mean you might have a plan. But I never even knew that. I was just ashamed that it crossed my mind. I think about the time that I spent in my OB's practice, lots of images of photos of smiling babies, smiling women. But what if we had a poster of something that's more informative with the language, so that coming through on the other end, you know what language to use when your providers and the people around you are asking, what do you need? And also just to validate that by sharing, it doesn't mean that your infant is going to be taken away. I thought if I said out loud, these are the thoughts that I have in mind, someone's going to say, then you don't deserve a baby.
And I want to highlight so much what you're saying about the environment. So it's not even just the messaging, but what we see. You're saying even like the pictures or the way that new parenthood or pregnancy or motherhood or parenthood is supposed to look like. If there's a mismatch, kind of like what Elise was saying, it's what's wrong with me, right? And that fear, you're bringing up that fear again. So the next question I want to ask is, for Elise and Dr. Neha or anybody else that wants to jump in your opinion, how can communities better support new parents or create an environment that promotes mental well-being during the perinatal period?
Well, I'll take this, again, if you're following along in the chat, we've been talking about this a little bit, but I think it really is community specific. I mean, look, there's some real true interventions that we know that works, which is interpersonal therapy. If you're a clinician on the call, like that's an evidence-based perinatal mental health intervention that's got a lot of evidence behind it, with the main purpose of it being how to bolster social support, because social support is a real in addition to stigma reduction and psychoeducation about what perinatal mental health is, that it is not who you are. It is something that is happening at the moment, like a mental health concern. Those kind of pillars really go a long way, but it really depends on community, right? And I think we were touching on this in the chat. There is a lot of systemic racism. There are a lot of agencies that don't have training. And even if we're trying to get that training going, some of the training will miss. For example, in DCFS, even if we get clinicians trained, there's a lot of non-clinical providers who wouldn't necessarily have access to that training, right? So it's really about education. Someone mentioned in the chat how frustrating it is that they have to educate their own providers, right? So it's how do we use the systems in place, like social media, like community centers, like churches or synagogues or mosques, if those are what is predominant in the area and you're working, to provide those psychoeducation groups. When someone asks, well, how do you get people there? They're afraid perhaps of intervention. It's like, you never say, when I work in community mental health, I'm never a therapist. I'm only always an emotional support facilitator. And if you're going to a group with a therapist or an emotional support facilitator, if you're in a marginalized group that is very fearful of systems, that sounds a lot better if someone's going to give you a taxi voucher or a bus voucher and is providing childcare. Yeah, then you can actually show up and get support that you need. Those things take money and financing, and it's really a top-down, who's going to fund those programs, like who in your community is funding those programs. So yeah, that's
I know that the PSI or just to add on for Elise is coming up with the Blue Dot project. So I feel that a lot of us as clinicians, providers should sign up for the Blue Dot project. That way we are certified maternal mental health counselors or providers in the community. That way people understand. And there should be very simple search engines as looking as postpartum provider, a perinatal psychiatrist, or a doula, stuff like that should pick up stuff which is very prioritized on a search. It's very hard for moms to gather their brains, but it's just so fogged. They're having attention deficit. They're dealing with their own symptoms. They're caring for a child and there's breastfeeding. There's a lot of layers on top of this that I noticed, which just prevents them from doing stuff. Even being 4 years postpartum now, I feel like I'm finally making sense of my child's life. The first 2 years felt so fuzzy. Even though I had all of this manual ready, I didn't know where to start because I just did not have the time, motivation, or the drive to do it. The very easiest thing that I would recommend that all of us should do is maybe get on searches or have searches so easily out there that people can just type up a word on their phone while they're breastfeeding or pumping is how do I find postpartum health? The first thing that shows up is PSI, which is great right now, but the PSI's website needs to be much more easily to navigate so we can find providers easily and we're not going through hoops and loops of dealing with insurance and all that stuff. So a lot of barriers still where either sessions are not covered or they're having to pay out of cash or out of their pocket. Last but not least, most important is support. Like, how do I get to an appointment correctly, as Elise said? Where do I leave my baby with? I mean, I allow patients to come with their infants, toddlers in my office. I would rather see mothers interact with their baby if they feel safe to bring them in rather than just have them. And there are certain offices that say no kids allowed. Why is that such a big stigma? Why can you not bring a child and feed your child and do everything normally in an office if you're able to? Maybe setting out like bus trips, pickups, Uber drive, stuff like that, if we can just help outreach in the community. The best thing for most mothers that are out there have their phones, if they can actually get on Instagram or any social media that's promoting these things on a weekly, monthly kind of basis, is one of the ways.
I just want to piggyback on something that you said that was so important, which is having parents be able to bring their babies. Always, always,
Exactly.
always. And I think a lot of traditional clinicians will say, well, but I can't really do therapy. And of course, their response is in perinatal mental health, that dyad or that couple is really important. And a lot of dads are grateful, right? Because they
Yes.
sometimes give a partner a break by bringing them and their babies in online. But thank you so much for that point, because for the clinicians out there, that's a really, really helpful tool. Please allow your patients to bring in their babies.
Yeah.
Yes.
Or even where it's permitted, like alternate, like bring them in, or there's walk and talk therapy where you can stroller baby. Some people do home visits, hospital visits for people that they have to stay in the hospital. So it depends on, what your practice is, what's going on. So excellent point. I want to take a moment to pause and acknowledge that Jessica Walker has joined us. It's so nice to have you here, Jessica, and thanks for joining our panel. If it's okay, I would love to have you introduce yourself just a little bit, and then we can continue our discussion. So the floor is yours.
Wonderful. Thank you so much for having me. So my name is Jessica. I have been an maternal mental health advocate for about 10 years now. I now co-founded an nonprofit it's a project. We're on our way to nonprofit status that was funded through Postpartum Support International, and just started off really as a campaign to bring more awareness to the postpartum age, right, in stage, right, around depression and anxiety, specifically for African American and Latino communities. So we really started there with a media campaign, and it's just blossomed into this amazing organization that actually deals with a lot of the things that Dr. Sarah, am I saying that correct?
Yes, it's Dr. Kinsara.
Okay,
You're fine.
Kinsara. I am horrible with names. Dr. Kinsara was just mentioning, right? Navigation of the healthcare system, actually getting access to care. And we created a care connector, which we're really super duper proud about, which I had a hand in. I love technology and social media and all the things. So that is what I currently do as the co-founder of Be Mom Aware, and also the co-chair of the Sacramento Maternal Mental Health Collaborative. We work along with a lot of county agencies, as well as all of the CACs and insurance companies, to bring that voice, right, of the mom, and just making sure that they're able to connect to care in the easiest way possible, without all of those additional stressors. We already have enough. I just literally had to deal with a bunch of them. So there's a lot that moms have going on. And if we could ease that so that they can get the help they need, we're just here to support and do that in any way that we can.
Thank you so much. I'm glad that you are here with us. And so for both the Jessicas and Brittany, what role do you see for family members and partners in supporting perinatal mental health?
So for family members, my the caregiving role in our household when I needed to pursue treatment. And he also had his own depressive symptoms at the time. So for him having to take on that role, our families also had to step up. Just because he was working full time, and we had a 2.5-year-old at the time when I was hospitalized. There's also like the role of my family is not my therapist, and they knew something was wrong, but I couldn't necessarily talk to them because they weren't my therapist. But they did help me find the programs that I accessed. They also helped me transition back into life here at home by offering a lot of assistance that honestly we're still seeing today. Here I am almost 3 years post hospitalization, and I'm still receiving family help today, creating kind of the village that we had hoped to have before then that we didn't, that we're trying to create now, and living into that. I definitely think that partners need to have more education. Either partners, whether it's man, woman, or anyone else who is in a relationship, because these perinatal mental health disorders affect everyone. And we know from research that 1 in 10 dads also experience a perinatal mental health disorder. And we don't have access to research on non-binary or gender non-conforming individuals, but we do have that research at least. And that number could even be higher because it's a self-reporting system. But I definitely think that when a partner or a family member is going to the birthing training or the parenting training, that this needs to be included in those trainings as well, so that they have that information. And then when the partner is, when, for example, I was seeking treatment, my spouse attended support himself, which I think is also the responsibility of anyone in the family to attend support groups. Being a spouse or a partner or a family member of anyone going through mental health treatment, whether that's through, is it SAMI? I think that's right. Maybe I'm wrong. Through like your local initiative or through whatever program you're in. So yeah. NAMI. Thank you. I was like something
NAMI.
AMI. Yeah.
And just to piggyback on that, actually, Brittany, I love the idea when people when they get pregnant, they are signed up with a hospital, and most hospitals give you the training for how to change a diaper, how to get your formula ready, breastfeeding, all of that stuff. I feel postpartum issues, perinatal issues should be a part of the education then and there, right there, because that could be a first step for anyone. I mean, I might know something that somebody else might not know, or somebody else knows more than I do. And we you know that the support group that I went to that was training me for the birth of my child, because I had absolutely no idea how to get a bottle ready or diapers and stuff like that. I learned a lot, but I was one thing that came to me is like, I'm the only doctor in this room, which is fine. And number two, why is there not a therapist in here even talking about the postpartum issues? Why is there not a packet given to me in there that says that postpartum issues are real? And instead of them being classified in the DSM-5 as a depression not otherwise specified, we need to advocate for it to actually have a codable diagnosis. So each one of them are segregated. Yeah. So I think that's where a lot of screening and a lot of intervention can occur as well.
Yeah, it's interesting, right? I've been doing this work for years, I remember a time and a point where I had gone and knocked on a congressman's door here in Sacramento, and they were like, "That's not an issue," right? And I'm like, "What do you mean it's not an issue?" And so I went and had some more conversations, and then I went to medical schools, and I was like, "Okay, are you even teaching this?" And they're like, "No." Right, so it's like now it's come full circle now, and it's like, well, I was had my daughter in my hands. She's now almost 11, and knocking on these doors going, this is a problem, this is a problem, why didn't I know about this, why isn't there more conversation? And now we're getting to a point where it's like, oh, maybe we should have that in some of our medical books. I mean, just maybe.
It is
Totally.
so surprising to answer that question. I was even going through 5 years of psychiatry residency. I was never taught this.
Yep.
I did this training through PSI myself and kind of learned this on my own. And I'm pretty sure the congressman you knocked the door on did not have a uterus and an ovary. So I don't know if they have exactly.
And also, you don't have to experience this as well, as I think what we're saying.
Right.
This touches all people. And I think like what you're saying, Jessica, Dr. Neha, everybody, is that, especially I'm part of the policy and advocacy committee, which Elise chairs. And like so often when trying to do this work, they're like, oh, it's a specialty issue, or it's a woman's issue. And actually it's a consumer protection issue. Actually, this affects children. Actually, this affects systems and families and everyone. And so it's kind of hard so I think like, one of my questions, we have like 10 minutes left. So maybe if you can speak briefly, at least, like what are systemic or structural changes you would want to see or advocate for in terms of perinatal mental health?
Yeah, and I think again, if you've been following along in the chat, there's a lot of work that we've tried to do. There's been a number of bills that have made their way with an attempt over the year, right? So 845 was one that attempted to mandate that MDs get training. For example, in California, we have 400,000 plus births a year, as Daniela had mentioned in her brief intro, but that's 800,000 parents more or less, right? Because it's two people or a sperm and ovary coming from separate situations, and perinatal is preconception to postpartum. So that's a lot of folks who are navigating this. You've got human sexuality mandated, and you've got child development mandated for all therapists, right? Whether they're a psychologist or a master's level provider. And the problem is there is no training on perinatal mental health. So it's not just that it's not in the DSM, it's that that hospital social worker you wish was giving you a packet hasn't had the training themselves. And again, like I said, my journey was with this, me printing out journal articles for my therapist 15 years ago, and they're still not training in schools, but we're trying, right? And if it's something that you feel passionate about, you can always connect with us, and we will put you to work trying to continue to knock on those doors, so that everyone understands this is a universal consumer protection issue, that depression and suicidality in the postpartum period is a really manageable concern if we have things like trained providers, stigma reduction campaigns, and more easy access to what happens after you get a screening. Because we do know that that's a barrier too. Maybe people have training in screening. Maybe there is a community area that's screening. But if someone's been given a PHQ-9 and they know how to use the PHQ-9, which is a screening tool, but what happens when that patient or that client screens positive? They don't have anyone to send them to. Exactly. And that's a real, it's like if there's a systemic change, it's that everybody understands, look, I might not have expertise. I might not be a PMHC in perinatal, but I have enough basic knowledge to know that I have to send this patient to someone who is a PMHC in the same way that we do for substance abuse or eating disorders, right? Like you get this basic training. For example, KDAC training, right, is a specific designation. But when you're in grad school or medical school, you understand enough that you have to send somebody to a specialty. We don't even have that right now. So to me, it's like when you're asking, what's the systems change? For me, it's really top down. We have a lot of wonderful bills about doulas and peer support. I think those are incredibly important. Those are two legs of a stool. You cannot just have peer support and doulas be thrown at sort of perinatal mental health as a Band-Aid, because they're not going to get treated towards wellness in the same way that if you have both doulas, peer support, psychiatrists, OB-GYNs, pediatricians, and therapists trained.
Thank you,
I
Elise.
get very passionate about that.
No, I know.
I love it.
My voice. I'm like, oh God.
You're room open for another hour.
Yeah, I love it.
So
I do want to add to that really quickly.
Yes.
I'll be super fast though. I think from my standpoint as an advocate and just as a mom, and then seeing other women respond to my story just by posting on like YouTube and things to that effect, women around the world, I said I had to do something about this. I wrote a book directly to moms and to providers, right? And having all the things going on in my head about I'm not educated enough or anything. I was like, I don't care. You're going to get this information. And then whoever wants to hear it, I will tell you, these are the things that are happening within these communities. And this is how you connect a mom, right? Because I hadn't gotten connected to care when I stepped up and said, hey, there's something going on. I don't know exactly what's happening right now. So I didn't want that to happen to another mom. So I just want to say to anyone that's out there that is an advocate like me, or training to be a peer support specialist, because that's the thing right now, right? You do have a voice and your story is so important. And it's just up to you to step up and go, you know what? If you're not educated in this space, that's okay. I'm gonna bring you over here and I'm gonna educate you on this part, on this front, right? So a lot of the things that we're doing with our providers trainings is around that. It's like we're experts on our own bodies, but we also have this information that we can give to you and help see to you. And hopefully you can spread that to the next physician, the next provider, so on and so forth.
I do have a question though, Elise and Daniela, since you guys have done this work for so long in the field. I know PSI has a directory, but is that directory based on like zip code or statewide? Because when I went in that directory and a patient told me, they weren't even able to find me, and they found me actually through Amen Clinics, and I was like a little disappointed because I'm like, wait a minute, I actually put my name in there. So tell us a little bit about it.
Yeah, so we'll at the very last minute we have left, we'll actually share the directory as well as some other resources, but there is a search field so you can search locally to you and based on specific specialties, but sometimes it takes a second to get uploaded. But we'll definitely touch upon that. And if that doesn't answer your question, just for sake of time, maybe we can offline it, but we will share that resource with everyone here today. Don't mean to cut you off, Elise, or anyone else, but I really want to hear from everyone with the last couple of minutes we have left, knowing that we have a minute to share resources. If there is something you want to leave everyone with, so if you can give one piece of advice for anyone working with or supporting a birthing person or new parent who is struggling, what would it be? And I would love to start with you, Jessica Walker, because we have not had to have enough time with you. I wish. So if you can kick us off, just one thing, we'll go around and then we'll share resources.
Yeah, so I have this acronym of HEAR, right? So actually hearing, empathy, um, awareness, and then, oh my gosh, I'm drawing a blank, of course, because I'm on the spot. But just responsiveness, right? So understanding that not all Black people have the same experiences and don't categorize people. Everyone has an individual story and an individual character. So making sure that you're understanding, not only reading the books, but listening to the music, really engulfing yourself in the community if you're serving that population. And I'll speak for Latina community as well. Well, I won't speak for them, but I'll say something about them as well. Same thing. We were hearing the same thing synonymous between the two communities.
I'll jump in with stigma reduction, right? That's the big takeaway because again, when you think about what the experience is of having a perinatal mood and anxiety disorder, that's something you have, not something that you are. And that's really the big takeaway for stigma reduction, because differentiating that this is something that is manageable, with help you will get better, that's very different than at your core, there's something wrong with you. And if there's one takeaway that you can really get from this on how to navigate your patients, your clients, your friends, your colleagues, it's not that there's something wrong with you. That's, please, stigma reduction.
Yeah, I think I'm going to go with resonating with both of them. And I'm going to say nobody needs to suffer in silence. This is real. And it's normal to feel the way you're feeling, but also that if you cannot reach out, there's help everywhere around you. I mean, I've noticed in the last 2 months how my Instagram kind of just blew up when I just started talking about maternal mood disorders and so many other things by just barely posting it. So if you feel afraid or guilty or feel sad about reaching out directly by picking up the phone and making a phone call to set up an appointment, that's fine. You can look at some social media articles, which are great. Gather the strength and talk to people who are really going to understand you. And I don't want people to suffer in silence, that's for sure, because we are all here advocating for each other and for all the moms and dads out there, everybody.
Yeah, I was gonna say it takes a lot of courage to say something. So
Absolutely.
I also agree, do whatever you have the mental capacity to do in that moment. If it's not getting yourself to, your provider's office, get on Instagram and listen to these stories so you're not feeling so alone and isolated.
Completely
My
agree.
advice is there can be growth around grief and loss. And that's for everyone, whether you experience it yourself or you're supporting someone.
I'd love to share my quick thought. I know we're at time, but really fast thought. As a mom, I didn't know what I needed, and I know that many of you are 988 supporters, and you might not experience the experiences that us panel people have. But when you come across a mom or a dad or a parent who is struggling with their mental health, don't ask what they need. Tell them what you can offer. I can offer, hey, I would like to bring you a meal. What do you like to eat? I'd like to babysit for you. When can I come? Or I'm available at these times. I can clean your house. So offer what you can do. Don't ask what they need. Take a load off their back. I think this goes to anyone who's struggling with mental health.
Yeah, this is so important.
Thank you so much. And Nargis, I don't know if you're still up there to,
I'm here. I just put the slides in the chat so people can have it.
Perfect. Is there any way we can project on the screen real quick, just so I can explain to them briefly what it is, or no? slide 26. Wait, are you there? Maybe I'll just share. I can share.
Yeah, if you can share, go for it.
It's not ready to be in present mode. Okay, cool. Well, first, before we fully run out of time, for everyone on the panel, like your contributions, your stories, your experience, your expertise, thank you so much for taking the time to be here and share this with everyone. My hope is that this is going to help, even if it helps one person, but my hope is going to help so many more. So thank you all. And some of your information is in the bio page, so people do have access to this afterwards. Ways that PSI can help you, and Narjis shared this PowerPoint deck in the slides. We provide scholarships for training. If you're in California through our chapter, you can request or organize a perinatal training in your area. We have a perinatal psychiatric consultation line for perinatal prescribers. And then there's also becoming a member. You have lots of benefits and access to that. There's peer consultation groups for therapists and providers. If you want to go to conferences, there's discounts. There's also the Perinatal Mental Health Alliance for people of color. And then we also have PSI fact sheets and infographics. Somebody was asking for some of the information in Spanish. So all of those infographics can be found like in this link, but under our store, and they're free, but you just have to go to educational materials. But you can also navigate our website in Spanish. And then ways PSI can help you or your clients is help spread the word for resources. We have the directory. There's PSI support volunteers. You can find a trained perinatal provider, and there's different ways to chat with experts. There's online support groups for all kinds of folks, as well as a PSI mentor program. And then Brittany is also the chair of like the climb. And so you can become a volunteer. You can be involved with your local chapter with Brittany, Elise, and I, and many other folks on that chapter. There's a form link if you want to support any of the board initiatives. And then you can raise awareness and build community by joining a climb. And that's a event where they're held all throughout California, all throughout the country. You can look it up, follow the link, and it's a great way to be connected with others as well as support the cause. I probably didn't do it justice talking about it, Brittany, because you're the expert. I say that every time. But thank you all for being here. Oh yeah, represent climb. Thank you for the work you do. Thank you for sharing, and everyone that's at this conference, thank you for listening and helping reduce that stigma to save lives. So I appreciate
Thank you so much, Daniela. Thank you for having us. Yeah.
Absolutely. Take care, everyone.